So the committee gave us 3 tasks that we had to address. Number 1, is dermoscopy effective, in essence, improved sensitivity at detecting melanoma? Number 2, does dermoscopy reduce the number of benign lesions? So in essence, does it increase specificity? And 3, which they felt was probably the most important of all of the questions, does dermoscopy lead to detection of thinner tumors? So I think the first one is actually the easiest one to address, maybe the second one as well. So is it effective at finding melanoma? And there are now at least 3 meta-analyses that are available that have looked at the world's literature and have shown for sure that it increases sensitivity by about 20% above your naked eye examination. If you look at the clinics that use dermoscopy and you look at the types of melanomas, the morphology of the melanomas that are being found, about 2/3 of those melanomas lack the classic ABCD features of melanoma. So asymmetry, border irregularities, color variegation, and a large diameter of greater than 6 millimeters. Now, one of the main issues that comes up, at least in the US, is that who needs dermoscopy? My eyes are just as good. So if I see something that's concerning, I just remove it. For me, it's a win-win. I make money because I'm doing the biopsy, and I'll know what it is. So who cares? But it took us a very long time to figure out the answer to this, which is actually a very simple answer. And that is that we're comparing apples and oranges. Okay? Now think about a universe of apples, and this universe of apples does not know that oranges exist. The world of oranges knows oranges exist, but also know that apples exist. So you have the world, the clinical detection of cancer. If you're only in that group, you're in the world of apples. You have no idea that oranges exist. The world of oranges are the dermoscopically detected cancers, and this group knows that these 2 worlds exist. So the apples are looking for this and say, well, if I see it, I'm going to remove it. Of course that's the case, right? What the world of apples doesn't realize is that there are melanomas that look like this that are completely escaping their retina. They're not even coming close to diagnosing these, and the only way they'll come to diagnose this is if by chance they biopsy it because maybe the patient forced them to biopsy it or there was some other circumstances, but they weren't concerned, and the biopsy comes back and they're horrified that the diagnosis is melanoma. In the world of oranges, that scenario almost never occurs anymore because we know these exist, and day before yesterday I gave a talk on difficult to diagnose melanomas where we went through these melanomas, and I think that is where dermoscopy has had the greatest impact, is it has allowed us to actually find a group of melanomas that 20 years ago, 25 years ago, 30 years ago, we had no idea they existed. And so an important principle arises out of this, and that is that if you only look at lesions that are of clinical concern to you, so you have already identified the lesion with your clinical eye as concerning, then the only thing dermoscopy can do for you is increase your specificity. It has no impact on sensitivity because your sensitivity is already 100% from your naked eye. Yeah? So with that, you look at this lesion, okay, it's a seborrheic keratosis, I've increased my specificity. That's an angioma, I increased my specificity. Angiokeratoma, I've increased my specificity. It's a clear cell acanthoma, I've increased my specificity. Right? So they're all clinically concerning lesions, but dermoscopy has increased your specificity, and you've said they're benign and you can leave them alone. Thus, the only way you can actually increase your sensitivity is to start looking at things that are beyond the ABCDs, right? And this is where dermoscopy has actually taken a hold much more so. So it's, in essence, thinking of outside of the ABCD box. And with that, we identified a whole bunch of these difficult to diagnose melanomas because of that, right? By looking at things that we were not looking at before. And so which lesions do you analyze? Obviously, clinical outliers, yes. Lesions that patients bring to your attention, symptomatic lesions, changing lesions. In fact, many dermoscopists now will examine as many lesions as is feasible. So maybe they'll identify one lesion that's an ugly duckling, but while they're looking at the ugly duckling, they'll also look at 10 lesions that are in the surrounding area as well, just for the heck of it, all right? And so that's sort of the way it's evolving, and there are many dermoscopists now that when you look at a patient with the atypical mole syndrome, for example, will very quickly look at almost all of the nevi. And it's not very time-consuming, and we actually published on that a bunch of years ago. It takes under 3 minutes to do the exam. And so with that, we have taken these lesions that were of no concern to the world of apples, looked at it with dermoscopy, and now we're able to identify focal streaks in one area. Actually, the pointer doesn't work that great. Peppering, dotted vessels, atypical network, and so forth, so on, and be able to identify all of these melanomas.